Hello and welcome to all to this webinar on the HIV Stigma Index 2.0, a critical tool for understanding and addressing HIV-related stigma and discrimination in the Global South, which is hosted by APA Division 52 International Psychology. This webinar is part of the series titled Vision from the Global South to celebrate the activities of psychologists that live in the Global South, to provide useful information for international engagement, and to encourage us to take a broad and global perspective. The webinar series has been founded by the Interdivisional Grant Culturally Competent Counseling, Vision from the Global South, in partnership with Division 17 Counseling Psychology. My name is Pina Marsico, and I'm the current president of Division 52 and your host for today's webinar. I want to thank the members of the webinar committee, Dr. Tio Lazarus, the chair, Dr. Tatiana El Noor, and Raffaele Modugno. And before we begin, our online audience have the ability to ask questions by typing them in the chat box located at the bottom left of your screen. Please feel free to type your question during the presentation. Dr. El Noor will be making note of them, organizing them, and during the last 12 minutes or so, she will present them to our speakers for discussion. At this time, I will introduce and welcome our guest speaker. Dr. Angelo Brandelli Costa is an associate full professor at John Cabot University in Rome, Italy, and a tenured professor at Pontifical Catholic University of Rio Grande do Sul, Brazil. His expertise spans from social psychology, health psychology, and public health, with a focus on HIV, LGBTQ+ health, and human rights. Dr. Costa has led large-scale research projects, including the HIV Stigma Index 2.0 in Brazil, and has been published extensively in top-level academic journals. He is a passionate advocate for using research to advance social justice and improve the lives of marginalized communities. I'm very, very happy of having you here, Dr. Costa. Please, the room is yours.
Thank you very much, Pina, for your kind introduction. Also, I would like to thank you in the name of the American Psychological Association for the invitation, both divisions involved in this seminar. I'm really glad to be here speaking about this research that is so impactful in Brazil, and I think needs an international audience to be delivered, I think, for a broader audience, as we are doing right now. So I'd like to talk with you today about the HIV Stigma Index project. There is an international protocol devoted to understand the stigma of this community, people living in HIV. But I'm going to discuss not just the research protocol and the research implementation in itself, but I also would like to discuss how psychology can make use of such techniques to impact in a meaningful way in people's life. So let's say psychology and research in psychology as a critical tool to address the healthcare and the rights needs for a community like the people living in HIV and in Brazil. So the HIV Stigma Index is a protocol, is a research project that was created by the Global Network of People Living in HIV. That is an international network of people living in HIV. And it started in 2005 together with the international community of women living in HIV and the International Parent Parenthood Foundation. UNAIDS is a key partner worldwide when implementing this research, also in Brazil. But this is a protocol or is an initiative that is led by the community, by an international organization that is a community-based organization. Nowadays, it's being implemented in more than 100 countries worldwide. I think I have a map here for you to show to you the countries in which Stigma Index was applied and countries in which Stigma Index is now in application. In some of those countries, the Stigma Index was applied more than one time. That's the case in Brazil nowadays, because we implemented it in 2019 and we are doing right now 5 years afterwards. If you enter in the website of the Global Network of People Living in HIV, you can see this map and then click in the countries to download the reports and see how this project was implemented in each of these contexts. This is a research protocol following two very important principles for the communities of people living in HIV. The principles are called GPA and MIPA. One is principle of the greater involvement of people living in HIV, and the other one is the principle of the meaningful involvement of people living in HIV. which means to say that we have an active participation of all the people living with HIV networks in all stages of the research process. In this particular case, people living with HIV designed the initiative based on their own needs in the global network of people living with HIV. And then, of course, in Brazil and elsewhere, they adapted the protocol for their needs. They are also, as we are going to see, paid in a meaningful way to participate as key informers and then also as interviewers in all stages of the initiative. And also they decide together with the researchers and the stakeholders how the data is going to be analyzed and how the data is going to be delivered to meaningfully impact their lives in terms of advocacy. So they are involved in all the stages of the protocol in a meaningful way, meaning paid to do so. This is the name of the initiative in Brazil. This is in Portuguese for the stigma index, HIV stigma index. This is the, let's say, the face of the research in Brazil. And for the construction of the proposal, we put together several organizations. Gestos is an NGO in Recife, Brazil, an NGO that works with people living in HIV, a community-based NGO. And Gestos wanted for a long time to implement HIV stigma index in Brazil, given the participation of Gestos in international forums, seeing how the research was implemented elsewhere. So Gestos, together with UNAIDS Brazil, invited the Brazilian networks of people living in HIV. So the network, the national network of people living in HIV, the national network of adolescents and young people living in HIV, the national movement of positive citizens, that is the network of women living in HIV, and the national trans network of people living in HIV, all together, and also invited me as the researcher, let's say the one managing the scientific aspect of the protocol, us all together working to adapt and recreate this initiative in Brazil in a meaningful way. So the networks of people living with HIV deciding what was their best interest. I was there to see the overall scientific protocol, and Just was managing, let's say, the community aspects overall. And UNAs and other UN agencies paying for the initiative and helping us, supporting us. We altogether decided that the research should happen in those cities based on the HIV prevalence and incidence, also based on political activism. For example, some of those cities needed a restart in terms of political activism, and the research, as we are going to see, helped this restart. But again, the both things, epidemiological reasons and also political incidents. So we choose cities on all Brazilian regions. Porto Alegre in the south, São Paulo and Rio de Janeiro in the southeast, Recife and Salvador in the northeast, Brasilia in the center, and Manaus in the north region of Brazil to be sites of this proposal. And I think this is the key difference of this research from other proposals. We recruited 30 people living in HIV in Brazil, respecting a diverse profile, considering gender identity, generation, race, ethnicity, sexual orientation. And those persons were not researchers. They are persons from the community. And we trained them to be researchers in psychology. So we discussed with them what is a survey on stigma in psychology is, how to conduct interviews and collect quantitative data, how to analyze that afterwards. So we trained those persons to be our interviewers and then our focal points in those cities, not just to, let's say, apply the protocol, but also to afterwards to understand the data and help us to decide how we need to present that data to impact people in a meaningful way. So we trained them in 3 days in each city to do so. This is a descriptive cross-sectional research, so it's a protocol that aims to assess in a quantitative way the stigma that people with HIV suffer in Brazil. We know that since the beginning of the epidemics of HIV, one of the key aspects is the stigma, because although it's a biological condition, there's a virus, we know that this virus, unfortunately, is surrounded by several stereotypes and prejudices. For example, attaching people with stigmatized characteristics based on the key population that is affected by the virus. Also, we know there are several barriers that are in place in healthcare services and also other kinds of services such as educational and workplace environments where people can suffer from loss of jobs to, let's say, denial to stay in school based on the HIV diagnostics, for example. So we know this and want to do this kind of mapping in Brazil in terms of how the stigma is displayed there. And again, another difference of this research protocol from others is that it's a person living in HIV from the community, not a researcher, that is interviewing another person living in HIV in those cities. So the idea is that even though it's a quantitative protocol, is to make the phenomenon of stigma visible for both of them. So for example, if somebody is answering a question about a situation that happened in a school, sometimes if you are detached from the consciousness of what stigma is, you cannot easily classify that experience as stigma. But other person that is trained to do so and live in the same condition that you live can help you to understand that situation and help you to classify and see it as something bad, as a stigmatized or discriminatory situation. That's why we ask them to do a paper and pen questionnaire rather than something electronic, because this facilitates conversation and create bounds, create a new network of people living in HIV besides the formal networks of people living in HIV. So put people together in contact in a meaningful way. This is another side of the project that for us is important. So it's an interview that happened and took somehow 1 hour and a half. We did an adaptation of the overall protocol because, of course, the global network of people living in HIV wants to compare all the sites worldwide. So we need to maintain a certain patronization, but we also need to include the characteristics of the Brazilian context, such as the way the healthcare systems work in Brazil, but also the actual needs of the population in Brazil. For example, one of the needs of our community was the fact that they needed to understand more the impact of racism and the stigma on the HIV stigma. This was something that we add on the proposal, and also they want to add mother to child transmission of HIV. For example, if you're born with HIV due to the lack of treatment of the mother, so they want to include that context as well. So we did a context equivalence and a review by an expert committee formed by members of those networks that I mentioned, and also the ones that we recruit to interview. We did that in translation after the adaptation based on the Brazilian needs. During the training in each site, we tested the new protocol and asked for inputs of all those interviewers to see if that new protocol was matching the expectations from each site. And then we did another adaptations. And in the end, the original authors from GNP Plus helped us to understand if the protocol was still meaningful for them in terms of comparability worldwide. This is the overall protocol. We have a section related to the descriptives on how people are in terms of their psychological, social, and physical characteristics. There's a section B called Revelation related to the way the diagnostics was informed consciously or unconsciously, for example, in the context of a breach of confidentiality. Section C is the core of the protocol related to the stigma's experiences. We're going to see the results in a while. Then we have a part on the internalization of stigma and mental health. We have a section E on the interaction with health services, discriminations and barriers inside healthcare facilities. A section G that is related to intersectionality, or the intersection between different forms of stigma that people can suffer, not just because they are living in HIV. So this is a key aspect of the stigma index. For example, we have different profiles of people in the community of people living in HIV. We have key populations, which means to say that so those populations are more susceptible to the virus due to their social vulnerabilities. Among those populations, we have men who have sex with men, we have trans persons, we have persons with history of incarceration, people that use drugs and other substances, and sex workers. So in the section G, we evaluated a stigma that you could suffer besides living with HIV, being a member of one of those communities. And also we add here, based on the inputs of our community in Brazil, stigma suffered for women for being a lesbian or bisexual woman as well, even though it's not it's not characterized as a key population. For example, by the United Nations, we decided to include based on the input of the community. So section G is devoted to those intersections between HIV stigma and other stigma. And we have section H that is related to the personal experiences of stigma, where people could report positive or negative experiences they had related to something they suffer. So it's a qualitative part as well. The research protocol was approved, of course, by an IRB board, in this case, the Catholic University of Rio Grande do Sul in Porto Alegre, Brazil, in the south of Brazil, where one of the places that I work. And of course, we follow several protocols because this is a very sensitive issue. We didn't want to re-stigmatize people because this research on that mere specific topic. So we know that it's a very sensitive information. For example, if you want to disclose your HIV status for an interviewer, and for any reason, even though we of course reinforce anonymity, but for any reason your diagnostics end up being public, this could mean you could put in danger, or it could be in a very difficult situation. So we reinforce it and asking everybody to fill forms related to the non-disclosure of let's say, those sensitive information from the interviewers to the data analysts, etc. This is a snowball sample, which means to say that we recruit the interviewers based on a very diverse sample characteristics. So I mentioned that we wanted to people from very young age to older age. I have all of them living in HIV, cisgender women, transgender men, gay men, cisgender heterosexual women, Black people, white people. So we choose a variety of people with history of activism and people without history of activism, because we wanted to, let's say, reinforce the idea that they need to contact their peers, and through a snowball sample, meaning that they needed to contact their peers, and then their peers indicate more persons, they will reach, let's say, several diverse let's say, samples inside this population. So we avoided doing, for example, research in the healthcare services. So because we know that we have already in the literature lots of research on stigma from healthcare services or other kinds of institutions, NGOs. We wanted people with history of background in NGOs, people with access to healthcare service, but also people that we could call naive in the sense, meaning that they are from the community, but they could reach their peers and then provide us with that information. And again, this is not just for the sake of information gathering, but also for the sake of helping those that are outside the more traditional networks of people living with HIV, rather than through a healthcare service or an NGOs, to connect via this research to, let's say, to this overall idea that we need to do advocacy towards the good of these people. They need to disclose that they are somebody living in HIV freely and publicly, residing in one of the capital cities, because in Brazil, the healthcare provision is geo-referenced, meaning to say that if you live in a capital city, you are going to be treated there. So we want to map also the way the services were being provided to those people in those cities. So they needed to live in those cities, be on legal age, and of course consent to participate in that interview. They were approached by one of their peers, and we think that facilitated the process. In the end, we got a final sample of 1,784 people living in HIV. We calculated the sample based on the number of people living in HIV in those cities, and also the prevalence of stigma based on other reports. This was the first time in Brazil we used that input other stigma index reports. We put together the prevalence of HIV-related stigma from Portugal and Argentina, and to have, let's say, a middle ground for the Brazilian sample size calculation, and we end up reaching the number that we need for the power calculation we did to start with. Okay, so what happened after we recruited the interviewers and they collected these 1,784 interviews? We gather in Brasilia, the center of Brazil, all together, all the networks of people living HIV, the Ministry of Health, UNAIDS, stakeholders, all the 30 interviewers gathered there, plus my team at university that were devoted to analyze the data for the first time. So all together, we arrive in Brasilia, and for 3 days we discuss what happened. So first we discuss the community aspect of it, how it was for them to do this job, Of course, we had a psychologist in the background helping any kind of situation that could be meaningful distress, that could generate distress online. So we had a psychologist online helping the interviewers and those interviews. But we wanted to do this again together to see how it was in terms of the impact on their lives and for the community. So we assessed the community aspects first, and then we together discussed the first round of data analysis. So we discussed all the data collected, and together with the community, they decided actually, which data should be displayed in the executive summary. This is the executive summary in Portuguese. Which data should be displayed to meaningful impact in terms of activism, and how the communication of this data should take place. So we decided that we should construct an executive summary with some data better displayed, let's say, in terms of what they needed to do first, and then with a hierarchy of needs in terms of advocacy. And some of the data we simply decided that would not displayed or displayed in a more trivial way, right? Because they were not impactful for the actual need of that population. I'm going to show you now some of this data in English. So I translated the images because originally it was in Portuguese. So I like to excuse if something is a little we can read it, but maybe it's not very well designed as it was originally in Portuguese. And then in the end, I'm going to show you some of the scientific, let's say, papers we did after the original executive summary. Because as I mentioned to you, this is something that should be done for the first place for the community, for advocacy, rather than just for scientific standards. And this is important to say. I was there as one of the persons participating in this, facilitating, let's say, the scientific aspect of it, and helping, let's say, the initiative to be scientifically sound. Because I know from my perspective that a scientifically sound research can do a better advocacy. That is the overall need for the community. So let's say we are putting together, I am there as a psychologist, offering my expertise for the community, for them to use this expertise for their sake, let's say, in terms of advocacy. So even though I thought that some of the data should be displayed first because for scientific reason this will be more publishable, this was not what was more important in that time. But afterwards we end up doing some research, as I'm going to show you. Okay, this is the first part of the protocol related to the demographics. I'm going to show you a little bit on that. So this is the composition in terms of gender identity and race ethnicity. So we end up with 62% of cisgender men, and I want to highlight that we end up with 30% of cisgender women. That is a very hard to reach population in the context of HIV stigma. We know that cisgender women end up suffering different forms of stigma in the community, and we are very happy that we have that population represented. We also have 5%, 6% almost of trans women, trans men, and travesti. Travesti is a Brazilian specific gender identity, so we end up also reinforcing the presence of that group as well. And I want to show you also that in terms of race and ethnic composition, those are the categories that the Brazilian Geography Institute used to classify people in Brazil. We also end up with the majority of Black and brown, pardo, somehow mimetizing the Brazilian population. I would like to say also that the mean age was 40 years old, and most of them, the mean age of them living with HIV was 10 years old. So we have the majority of people around 40 years old living with HIV for more or less 10 years. This is one of the most striking findings. This is before COVID. We collect data in 2019, before COVID. So we asked in the past 12 months, how often were you not able to meet your basic needs, food, shelter, and clothing? And we can see here that almost 50% of them told us that in the last 12 months, sometimes or most of the times, they would not be able to meet their needs in terms of clothing, shelter, and food. This is already speak by itself, the context of the unemployment rates and the let's say, workplace discrimination of people living with HIV, that we will see further how it was displayed in Brazil. And also, I should like to add that the World International Labor Organization end up joining the initiative now for the second wave, due to the fact that employability was one of the key aspects that was highlighted by the community and the research. This is the core part of the protocol. that is called the experiences of stigma and discrimination. So those are all the possible answers for this question that asks if the participants suffer any of those possibilities of discrimination. Those possibilities were raised by the International Organization of People Living with HIV, but they were also revised, and we add some new by the Brazilian needs, the needs of the Brazilian community as well. So, for example, have you ever heard of other people other than the family making discriminatory comments and gossiping of you because of your HIV positive? 46% of people said yes. 41% said that this happened in the context of their families. So this is very sad. The families being discriminatory against their own family members due to the HIV diagnostics. 25% said that they were verbally harassed because of their HIV positive. 20% also said that they suffered discrimination from their husband and wives. Around 20% said that they lost a job or income due to HIV diagnostics. We heard several, let's say, histories of people that lost their jobs because the diagnostics were revealed without consent, or because they were tested without consent for a job interview, and they end up losing the job they wanted due to the diagnostic. So this is very sad. That's why I mentioned to you that this impregnability was one of the key issues raised by the community. 17% said that they were excluded from family activities due to diagnostics. 17% also said that they were excluded for social gatherings rather than the family. 30% said that the nature of their job changed, or they got denied, a promotion denied due to the diagnostics. Blackmailing, 10%, 7% said that they were excluded for religion activities, and 6% suffer physical violence. You're not going to suffer any of those things if you end up getting influenza or any other infection caused by a virus, even from a bacteria or any other biological condition. But HIV, and you can see here, this is not the first decade of the epidemic. This is 2019. Make people suffer all of those things. We know it's ecology based on the theory of minority stress, that we all suffer stress in our lives in general, and this is bad for our physical and mental health. But if you are a minority and you suffer this extra stress, besides the violence you are suffering and the denial of jobs and opportunities, this extra stress in itself it's very bad for your mental and physical health. So what we are witnessing here is this extra stress that people suffer, and we know based on the literature that is very pernicious for their overall well-being. So in the end, if we sum all those scores, we will reach this conclusion that 64% of people in Brazil already suffer discrimination based on their HIV status. And we end up publicizing this because the community asked us to deliver, let's say, this news in the newspaper and to create the advocacy around that particular information in the beginning. This other part is called internalized stigma, or the way you feel about yourself and resilience. So this is, let's say, is a psychological internalized aspect of that stigma that people suffer socially. And I want to show you also this. For me, this is the most striking and sad part, because we end up thinking that this is something that was related to the beginning of the epidemic, because we are in the 4th decade of the HIV epidemic. But no, this is true also nowadays. So, for example, 81% of people told us that it's difficult to tell other people that they are HIV positive. This is a proxy for the amount of stigma we have socially. If it's 81% of people are telling us that it's difficult to tell other people, it's because they are fearing social sanctions to do so. 75% of people actively hide from other people that they are HIV positive. 36 feel ashamed, 35 feel guilty, 23 feel worthless, and you see 21 feel dirty about their HIV status. So you see lots of people think that counseling, psychological counseling in the context of HIV health is something that we should not do, because now we have rapid testing, pharmacies, etc. But for me, this is why we still need to put psychology in the table to discuss the psychological impacts of HIV until today, because we are seeing here how this is a burden for the Brazilian community, but I'm sure this is true elsewhere, because psychology, unfortunately, is being put aside. Also, sexual health education overall in educational context, but in society in general, is now also being put aside. And I reinforce the need due to the fact that people are suffering based on, let's say, those aspects. We have another section called human rights and let's say effective changes. It's a more positive side of the questionnaire, even though we also ask about violation of sexual and reproductive rights as well. But I would like to emphasize those questions to see a bright side of this data. We know from the beginning of the epidemic that the HIV community is very active in the context of solidarity, in the context of teaching other people about their status, in the context of acting upon the government, international agencies to make their case be heard and also to make their situation being changed. So here we have several instances in which we can see that this was true. For example, 66% of people provided emotional, physical, and other support to help someone living in HIV to deal with stigma. So you see how solidarity is one of the key aspects, and still today, for this community. In Brazil, for example, maybe some of you are familiar with this. We had a very important federal program devoted to change, let's say, the status of HIV epidemic in Brazil. And it was founded by the synergy between the university, NGOs, the community, the government, international agencies around, let's say, the idea of solidarity, fomenting the community for them to act on their own, let's say, peers. And I think we are seeing this here in this data. 57% confronted or educated someone else that was stigmatized. 35%, for example, participating in campaigns. 20% encourage a community leader to take actions. 40% spoke in the media. So this is, let's say, is one of the bright sides of this community, how they are solidarity bonds, put people together and also help them to change their status. And the research also has this need. When we put people living in HIV talking with each other, it was also to restart, let's say, this solidarity aspect of it. This is a section called Interaction with Health Services, where we discuss several aspects. I'm going to show you a research in the end to discuss this in particular. But for example, we had here 47% of people reporting mental health problems. This was also another area in which the community asked us to create advocacy around the impact of discrimination that they are suffering on mental health. Now we are doing the second wave. I'm going to show you in the end. And this is when was again highlighted as one of the key areas that they want us to intervene, because you see this is a enormous prevalence of mental health problems in that community. But see here, this is a very sad aspect of the interaction with healthcare services. So in the last 12 months, so it's 2019, because you are HIV positive, has a healthcare professional done any of the following actions? So imagine 6% told us that a healthcare professional told them not to become mother or father. 3% more or less pressured or encouraged the person to be sterilized. 2% almost said that to get an antiretroviral, they need to use contraception. Well, almost 1% denied a contraceptive or family planning services, and 0.4% reported us that they were sterilized without consent. So you see how it's not in the 80s or the 90s. It's until today in Brazil, the need for medical education in order to avoid the misconception, because if you were treated for HIV, there is no problem for you to have a kid. And again, this generated in the Ministry of Health in Brazil the need for a very large federal sponsored training project for Brazilian healthcare professionals that we end up also helping to implement. And here in the end is the section devoted to the stigmas related to the other identities, not just because you are somebody living in HIV. So we also consider several instances of stigma because the person was gay, bisexual, or another man that have sex with men, lesbian, bisexual, or other women that have sex with women, trans people or travestis, as I mentioned, a Brazilian specific transgender community, sex workers, or people who use drugs. All of those populations, if you disclose that you are a member of one of those, you answer also a questionnaire on the stigma related to that identity. I'm going to present just a snapshot of that aspect here. Oh, no, I'm not, in fact. But I just want to highlight that we end up producing data, for example, the amount of discrimination that you suffer because if you are a member of those communities. So after the first phase of this executive summary, we gather again, and the community decided that we needed to do in-depth analysis of some context. And not just that, but then go again to each of those cities with seminars, providing information on the executive summary, but also providing information on those contexts that were more meaningful for each city. So we produce very small, with small, let's say, some protocols or executive summaries, but with in-depth analysis. And we consider, for example, the data from the cities. So we did one from Salvador, Bahia, another one from Recife, São Paulo, Porto Alegre. So we did from the cities, but we also did from key populations. So we did one for men who have sex with men, one with cisgender women, one for trans people, and another one from the Black population. And then we launched those in those seminars that we did in each city, inviting key stakeholders from the city. So we invited the juridical system, healthcare professionals, the NGOs. We sponsor again the participants to be there. Also, academia, people from their community to discuss the data and to think about meaningful solutions for the problems of each city based on the data. So, for example, in some cities, we saw a large number of people that lost their jobs due to the fact that they were HIV positive. And we end up putting together in those seminars a group of people that, for example, worked in a legal petition for the court in a collective action to re-employ those who lost public jobs, for example. And we knew that this was successful in some of the contexts. In other contexts, for example, this helped the municipality to implement courses for healthcare professionals of finance, NGOs, in order for them to act in a specific aspect of the data that the data show it was problematic. This is the picture of one of the seminars that I mentioned to you, in which we discussed the data. I think this is the one that the executive summary was already launched, and then we discussed the need for the in-depth analysis. So those are all the interviewers and some of the stakeholders that participated in the initiative in the headquarters of the World Health Organization in Brasilia, in Brazil. And I want to highlight here that this is not, I'm just speaking as one of the members of this very large initiative. As I mentioned to you, I'm speaking from the standpoint of the research, from the standpoint of psychology, but this is not done only from the standpoint of psychology and research. I'm there, let's say, to reassure the need for the scientific standardization of everything, but this is a project that is done from many hands, and I'm just speaking about this initiative very humbly, that I need to reinforce that is based on the need and the work of several communities that help together to make this happen. Those are the logos of the communities that participated from the beginning, and those are the names of each of those that participate, the interviewers and the members from the stakeholders and the members of the national organizations participating. So again, I want to reinforce that I'm just one of the arms, let's say, of this very broad initiative. And moving towards the end, I'd like to reinforce that, of course, since I'm from the academia, I also have some, let's say, academic perspectives over what should be published, not here in terms of the community engagement, but in terms of scientific engagement. So the first thing we did was this paper published in AIDS Care called Key and General Population, HIV-related Stigma and Discrimination in HIV-specific Healthcare Settings. I decided to deliberately ask all the principal leaders from the Brazilian NGOs that participated in the initiative to sign this paper with me. So I'm signing this paper with the leaders from the community. So it's me plus the community members because we did this together. And what we did, we put together all those who are from the key populations. So sex workers, trans people, men who have sex with men, people with history of incarceration, and also people that use substances. And we compared that group, that is a group that is more vulnerable, have higher prevalence of HIV, more vulnerable in terms of social vulnerability because of the discrimination due to the other identities. and the lack of legislation and specific healthcare services. So we put them together and compare them with the general population living with HIV in our sample. And we want to see if there is a difference in terms of stigma that they suffer in healthcare services devoted to HIV. And unfortunately, we saw that that's the case. So this is the comparison. So in the last 12 months, so it's 2019, this is not in the beginning of the epidemic. Any of those things happen to you because you are somebody living with HIV in the healthcare facility devoted to HIV. So the physician avoided to physical contact using extra precautions such as wearing 2 gloves. We saw that this happened for more or less 7% of the sample. There is no difference in this variable. But again, you see, this is people studying and working with people living with HIV. Being talked about or gossip about, 6%, but there is a difference. This is more frequent in the key population rather than the general population, almost two times. Telling other people about your HIV status without your consent, 5% in the total, but again, is twice key population versus general population with HIV. So those who are more discriminated against and should be more protected are more discriminated in the context of HIV care in Brazil. Being advised of not having sex, 4%. This is completely against the overall protocol nowadays. If you are treated with a suppressed viral load, there is no problem of having sex, mainly with or without condoms. Verbal abuse, almost more than 2 times higher among key population compared with not general population. Denial of healthcare service, 2%, no difference. And physical abuse, 0.1%, no difference. But overall, we saw that one of those events happened to key population. 70% of this is the frequency, 70% of them, and for general population, 10% of them. Again, 1.7 times higher key population among general population. So we end up making the case on how we need to reinforce that key population in healthcare services devoted to HIV should be better protected because they are not, let's say, they are being more discriminated against. We also did a paper, qualitative analysis of the qualitative answers of the protocol, and we did a paper now on the difference between stigma suffer from women, cisgender women living in HIV from a low socioeconomic status and with a high socioeconomic status, showing that cisgender women with low socioeconomic status end up suffering more stigma than their counterparts without any kind of socioeconomic vulnerability. This is also published, but I'm not showing you here. If you need more information on that, I'll be happy to share to you later on. As I mentioned to you, we are now in the second wave of the data collection. Several of the questions that we ask concern lifetime prevalence of stigma and also the last 12 months year, let's say prevalence, last year prevalence of stigma. So we can use that prevalence, last year prevalence, and do a timeline, monitoring trends in terms of how stigma is going up and down. So after 5 years of effort, we end up putting together the money for doing this. This is being paid by CDC in the United States, the Center for Disease Control, and Fiocruz in Brazil. So we are now in the middle of the data collection of the 2014 Stigma Index in Brazil. This is the new consortium. So we have the same networks of people living with HIV with the addition of the national articulation for the fight against AIDS in Brazil. As I mentioned, CDC and Fiocruz are paying this time, and we have also as a stakeholder the Ministry of Health in Brazil, UNAIDS, and me again from PUC. So we are now doing this again in the same cities, trying to show a new photography, let's say, of the stigma in Brazil, and helping again to do a better incidence for people. There is some new aspects. So we already recruited the interviewers, and they are now collecting data in the sites. And I just want to reinforce that we have now new aspects that the community raised to us that are important for them. One of the aspects is climate change. For example, Porto Alegre, the city in which I came from, we suffered a severe flood this year. So they want to discuss how those extreme climate events impact the healthcare provision in the city, also the impact of COVID-19 in their healthcare and discrimination. We included a chapter on intersex population, against stigma related to intersexuality. They want to reinforce racism as one of the key issues in Brazil in healthcare services for people living in HIV. I'm sorry if it remained in Portuguese here, but I will translate it to you. They wanted us to do a better investigation on gender-based violence, sexual and gender-based violence, mainly amongst cisgender women. So we did that. And again, as I mentioned, reinforcing the variables and the data collection around mental health. This time we have a very good scale to screen for mental health because they want to reinforce the data on that part as their part two. So this was, I want to share to you the photos from the training because we already finished the training. They are now collecting data. So this is us, me and the team from Gestos and UNAIDS together with the interviewers from several regions from Brazil. So here's Bahia, Recife, and São Paulo. This is Brasilia, Salvador, and here Porto Alegre and Manaus. I would like to say to you all that I truly believe in this initiative, the power that it has to restart, let's say, activism, the power that it has to make people work together in a meaningful way, to create bonds of solidarity among people, to visibilize a phenomenon that it can only be visible via the discussion on the peer discussion. And and I want to also share to you the idea that for me, this is one of the beauties of psychology. If from the way I work, that I, as I mentioned, put my knowledge for the sake of the community. So I'm there as a, let's say, a facilitator for them to navigate, let's say, the stakeholder environment or the advocacy environment, using this research as a tool for their own meaningful changes for their status individually, but mainly collectively. And I think, that's it. Now I'm happy to discuss with you questions. If you have questions, if you have doubts, and if you want more information of any other topics, I'll be happy to share with you. Thank you very much.
Wow, fascinating, fascinating, Dr. Costa. This has been really a very inspiring presentation. And so we're going to open the floor for questions. We already have a question posted by Anna, who congratulates you for the presentation, but also would like to ask about, when it comes to data of health services, do you think that it's occurring a trend of an increase of right conscious?
Of what? Sorry.
Of right conscious. So when it comes to the data of health services, do you think that the trend is going in the positive way that you would like it
Okay.
to be?
Okay. I think unfortunately we're gonna see a worse scenario nowadays in 2024 in Brazil. But I would say that in several places in the world, unfortunately, because we are seeing that for one side, sexual health discussion in public and also in institutions are becoming a more tense subject. So we are seeing several organized groups in society asking society in general to not speak about this anymore. And I'm just showing you a side on how it's needed because people that live with HIV, they are suffering from it. And we are seeing in Brazil, in some regions, an increase of prevalence of HIV. In syphilis, we see explosion worldwide. Also, we know sexual education works for different aspects of gender and sexual violence. So unfortunately, the lack of this in overall institution and socially, let's say, for me, is going to impact on the discrimination in healthcare services. And I think also due to COVID, due to the extreme weather events, due to also the last federal administration in Brazil that was not sponsoring and discussing and doing things in a meaningful way for this community, we are going to see an increase of discrimination in healthcare services. We saw, for example, I want to share with you in Brazil, this year, we saw an enormous breach on the confidentiality of the patients that were being assisted in a public clinic in Brazil. Their diagnostics were exposed without their consent, and we saw this unfortunately had a tremendous effect on their life. So for sure, we are going to see this unfortunately a worst in this scenario of a stigma.
So how could you use the HIV Stigma 2.0 index to support a change or to drive change in healthcare policy and also in healthcare delivery?
Okay. Via several angles. Of course, I'm a researcher. I work together with those international organizations. I also serve in some panels for public administration. So I would say, from my perspective, I would say, well, if you gather data and you show the data for the stakeholders, they will implement something in a meaningful way. But as I mentioned in the beginning, this is not something that is scientifically driven only. This is driven also by the need of the community. And it's also a community intervention at the same place. So what is happening is that one of the ways it changed the healthcare status in a meaningful way is that by putting people together in a community, let's say, discussing this openly, this already creates venues to re-engage people in a more interesting conversation, because we know that the peer education and also this peer connection is a way for them to navigate stigma in society. So they are able to connect with, let's say, health organization, mental health organization, legal services, and during the data collection, we help them to do so if they need it. But of course, via the bounds created, this will happen later on too. The other thing is that the community itself empower itself with the data, and then they can use this to generate a positive change for them. So for example, now for the new data collection, we are scheduling a public audience in the Congress in Brazil, in the main tribune, to discuss this. It's not going to be, I'm going to be there, but this is not something that I need to present. So the community is going to present this, and if they need any kind of, let's say, scientific input, I'll be there to help. So let's say we are helping to push the response via the community with this research. So it's not just data collection that is important too. The papers published, the way we visualize this data that is in Brazil. This is the first time a research is conducted with this subject nationally. But for me, the most important part is to empower the community to do that in their own standards.
May I add a little? I have a little question and curiosity, Angelo. May I, Tatiana? Thank you. Yeah, thank you very much, Angelo. Your speech has been extremely interesting. I've been for a while following this work, but now with your presentation, now I have a clear picture. And for us and the Division 52, this is an extremely important example of community-based intervention on the large scale. What we have seen and what we have, let's say, over the year, we have had many other colleagues that brought in this webinar series lots of different perspectives and experiences, but were always, let's say, related to some specific context, which is important. But in your specific case, yes, it's Brazil, but in very many different places. And those places, for people that know Brazil, are not the same. They are very different in terms of, socioeconomical condition, and some healthcare systems are very different in the capital and in other cities. So I was wondering, Angelo, if there have been differences in implementing this large scale intervention in different spots, because one thing is working one single context, and different things is providing the very same intervention with this very same philosophy of intervention in different settings. Any comments from your side?
It is a very interesting, I think, and also there are some difficulties, but also some beauties in doing that. Well, first, from the standpoint of the GNP Plus, the global network, this is amazing because this is being done in several countries. So how powerful this tool is in order to be meaningful for so many people. But from Brazilian perspective, we know that to influence the federal agencies that do is the federal government that sponsors the healthcare system in Brazil. So we need to have nationwide data in order to provide that. But we know also the particularities of each community. So what we try to do both things. So we go to each community and we recruit members that are meaningful from that community. For example, in Manaus, we tended to look for people that are indigenous, with indigenous background, in order for us to make them participate in that and see via their angle. In São Paulo, we recruited several digital influencers that were nowadays working in those social networks, doing a very interesting job on those topics as well. So we tended to look to how those specific places were, let's say, offering in Recife we had in Salvador, a very strong national, local NGOs. So we recruited people from those NGOs. In other cities, we recruited people from the church, working with church. So we tended to look for the needs for those communities. And then we tried to adapt the questionnaire using the input from the community. So if in Manaus, it's important to look for breach of confidentiality, and in Salvador, it's important to look for workplace discrimination. We ending up adding everything that people need is meaningful. So now we're going to do the overall summary with them in Brasilia in 2 weeks, actually. I'm going to go there to discuss the data for the first time. And then we are going to do for sure the specific reports based on the needs. Because, for example, in Manaus, they're going to say, oh, for us, we saw several people talking about this, and that. And then we do a specific report to help them to intervene in that specific area. So we tend to do this because for one side, we know that nationally, this is important for the United Nations, for the federal government. So we need national data. But we need also to look for the specificities of the people in the field. And again, Pina, this is also a thing for international psychology, and I think for community psychology in a national scale or international scale. We need to sacrifice some things. So we need to make this comparable, because there are some people working with international psychology at GNP Plus that need this questionnaire to be comparable. So they want to compare Uruguay and Brazil and Italy. So we need to make this possible for them. But we need also to make this meaningful for the community. So we need to put this together, given the fact that this is something bigger. It could be something particular, but then we will lose comparability. So all of those things need to take place, and we discuss this with the members of the community. They are not experts in psychology, but as I mentioned to you, my role there, and I think in all community intervention, is to educate people on those things for them to decide with us which is best for them, based on what we lose and gain with each possibility.
Thank you very much. This is very, very meaningful, because this negotiation that is so delicate, so important to make. Otherwise, the community which is providing the data will be, let's say, lose the grip of, or lose the let's say, the authorship in the big picture, and lose the role, lose the protagonist. So yeah, it's very, very difficult to keep this balancing the, let's say, nomothetic and ideographic perspective on all those things. Thank you very much for your inspiring.
This is one of the things I like to do the most. That's why I like to work in tandem with the United Nations agencies and those communities, and the governments. This is the kind of thing my research is about. I tend to do research that is meaningful for the communities, also meaningful for the government. So I try to put together those perspectives, negotiating this with those, let's say, stakeholders. And for me, if we are doing a community-based research or something that is meaningful or applied research in psychology, if you do not do this, it's not going to be meaningful for the people that are there, then need for that intervention. So for me, this is something that is together with the research that I do.
Yeah, incredible. Thank you. Over you, Tatiana. Thanks.
Yeah, I think maybe the final question before we close.
Okay.
Angelo, is so you're really focused on the people's action, using data to deliver that action. So how do you get to motivate people?
Well, this is another thing. I am really motivated on that. So I like to do this. So I try to share my motivation. And I would like to tell you this. Unfortunately, in Brazil, we are facing a moment that those communities were really underfinanced, and they are now different from 2019 in a context in which they feel this is meaningful, or this is not enough. But I am reinforcing that we have now key channels in which we will make this meaningful. We will help them to make them being heard via the research. And this is a process to motivate people, to make them understand how, for example, somebody that is in the government and maybe are not an ally in that cause will be more convinced using a quantitative data rather than a qualitative data, for example. So I discuss with them and how we need to maintain a scientific standardization, because somebody in the government or in an agency will like better or will believe more in the research if we do this in that and that way. So this is a part of the process in which we try to show the channels and how the channels operates in terms of the data that is available or not, to make them believe in the overall proposition. But this is also a process. It's not just me, as I mentioned to you. We have other NGOs and stakeholders helping this process too, to make people know together in this initiative. But this is a key aspect, and I think, unfortunately, in Brazil now it's difficult after some years of underfinanciation of the organized civil society.
Brilliant. Thank you very much. Pina, over to you for conclusions.
Yeah, thanks a lot. Just briefly, I want to thank Angelo Brandelli Costa for his inspiring talk, and all the group of the webinar committee of Division 52 for organizing this webinar. We hope that we will have all the opportunity for learning, how the things are developing, Angelo, maybe next year. And I will really thank you for this talk. Tatiana, last words are with you, as always. Thanks a lot.
Thank you very much, Pina. And I think without further ado, we would like to remind everyone that our next webinar will be actually coming in shortly on December 3rd. But this time we'll be discussing reproductive justice and looking at a special issue of international perspectives in psychology. So we hope that you join us at 12 p.m. Eastern Time. And without further ado, thank you very much, Dr. Costa, and thank you everyone for your attendance and for bearing with us today, and look forward to seeing you again. Thank you.
Thank you. Bye-bye.
Bye. Thank you very much for attending, for the invitation.